Hello, I want to talk to you today about some new research that I've been working on with several colleagues about the age specificity of infection fatality rates for COVID-19. This is joint work with Bill Hanaj, who's a professor at Harvard Public Health School, Gideon Merowitz-Katz, who's an epidemiologist in Australia, and Kenzie Cochran and Seamus Walsh, who are recent graduates of Dartmouth College. This paper is a systematic review, and I'll explain in a moment what that is. It's a meta-analysis, and then the end of the paper, we look at the public policy implications of what we found. So let's dive in. The first point is that it's challenging actually to assess the severity of COVID-19. There are several reasons for that. One is a lot of cases are asymptomatic or mildly symptomatic. Someone loses a sense of taste for a few days, or they have really severe headaches. Some people have described it as the worst flu they've ever had. And those asymptomatic and mildly symptomatic cases may not show up in any kind of official case reports. Another problem is that live virus tests, which are called RT-PCR, there's been variations in availability of those tests over time across different places. And the extent to which those tests have been used more for some demographic groups and less for others. In cases where we have good measures of this, for example, younger people tend to get tested less than older people. And so there's systematic differences across demographic groups. An alternative which has become much more common across many locations in the last several months is what's called a seroprevalence study, where they collect specimens and do antibody tests to detect what fraction of the sample has been exposed to the virus. Those seroprevalence studies can be really helpful in assessing how many people have been infected, but there's a lot of variation in the design of those studies and the sample design and how they report their results. One consequence of all of this is there's been just this enormous divergence in results about how severe is COVID, how dangerous is it? And that's fueled in very intense controversy in the public square about how public health measures and communication should respond to this to make sure that people are protected. Just to give an example here in New York City, this is data as of mid-July. There's 8 million people living in New York City. There was a seroprevalence study done very carefully by the New York Department of Health using a randomized sample that's representative of the general population. And they estimated that about 1.6 million people in New York City were infected with COVID as of that date. About 2/3 of those were symptomatic cases. Only 1/10 of the estimated infections showed up in case reports, 12%. A fraction of those required hospitalization. The net bottom line is that only 1% of the infections resulted in fatal outcomes. So it's like finding a needle in a haystack. But what you should realize is 1% is a very serious, very dangerous disease. By comparison, that's 20 times more dangerous than seasonal flu. So here we have at least one benchmark from New York City. And again, it was a study of New York State. We'll look at those results later. But this gives us at least one benchmark, a reference point. Now, what are we going to do in our analysis? First is to do a systematic review. There's a lot of studies, I'll show you in a minute. We got to sift through them. Not just seroprevalence studies, but also looking at countries that have done tracking and tracing. That can be really valuable accompanying evidence because it doesn't rely on antibody tests. It's actually using the RT-PCR results. The next step is to do a meta-regression for the included studies and to analyze the relationship between the infection fatality rate and age. And each observation in the meta-regression is coming from a specific age group for a particular location. We also do some out-of-sample analysis. I'll mention that in a minute. And we compute population IFRs. That's the technical term that means of the total number of infections in a given location across all age groups, what fraction of those resulted in a fatal outcome. And so that's a really important way to think about severity of COVID. Okay, so the systematic review We exclude studies that are from non-OECD countries. We recognize that developing countries have challenges in healthcare systems and in reporting of public health data. And so that just was beyond the scope of our study. We also exclude in a systematic way non-representative samples from hospital patients or blood donors, kidney dialysis patients. And in the paper explains exactly how we made those decisions, so I won't go through them now. Then the next step is to do assessment of seroprevalence. Some studies reported raw prevalence. They call it seropositivity. The problem with that is that the test sensitivity and specificity are not perfect. And so one of the things we do in the paper is to adjust for test characteristics. And again, there are more details there you can read about in the paper. And the final step is how to measure fatalities. We look at all confirmed COVID deaths, including nursing homes, including hospitals, and including people who died home in all the cases where that data is available. And we look at fatalities as of 4 weeks after the study midpoint. Let me just show you a picture here. Why we settled on that is the baseline criteria. The CDC has documented, and others have too, that from the point that someone's infected, it takes some time to develop symptoms. This figure shows you what happens on average after the onset of symptoms. The fatalities sometimes happen within a week or 10 days, but sometimes it's several weeks or a month or more. And then there can be a week or two of reporting lags before it becomes part of the official reports. So it's really important not to look at fatalities at the same time as the seroprevalence study was done, rather to look 4 weeks later if you want to look at the total tally, the total death count that corresponds to the number of infections at the time of the study. Okay, this is what's called a meta-analysis flow diagram. It's a standard way of showing meta-analysis of how you sift through the studies. You start in this case with 1,149. A lot of those are excluded because they weren't OECD countries or they actually didn't report seroprevalence results. They had seroprevalence in the paper, but it wasn't a seroprevalence study. So then we review 116 studies in depth. We exclude 83 of those for the reasons I already mentioned. And what we end up with is 23 seroprevalence studies, which includes 9 national studies: England, France, Belgium, Spain, Italy, Portugal. I'm sure I missed one. Anyway, you can look in the paper. 19 national studies and 14 regional studies, including a bunch of regions within the United States, as well as 5 countries that have done comprehensive tracing. And what gives us all together is 108 observations for the meta-regression. That means 108 age-specific category where we have seroprevalence and the confidence interval for that age category in that location. And then a few more observations that we use for the auto-sample. So here's the results. And it's remarkable. I didn't know what we were going to find when we got into this. I thought it might be just a total mess. But actually, there's a remarkably consistent pattern here. Once you select out the studies that we excluded for systematic reasons, you start to see a very consistent pattern. Now, in this case, the red line is the meta-regression estimate. It's a log linear regression. So this is on a log scale. The confidence interval is the 95% confidence interval around the meta-regression. The meta-regression method uses random effects, which allows for random deviations across different observations of different age groups and different locations. So the prediction interval refers to that. The different dots in this plot, some are representative samples. They designed the study to be representative of the population. Some are what are called convenience samples, which could be that these were samples that were for laboratory tests. So they're not as representative, but maybe still reasonably representative. And then the green squares are the 5 countries that did comprehensive tracing programs that we identified. And again, very consistent pattern here. Clear upward sloping relationship between IFR and age. But it's a log scale. So what we also do in the paper is to show it in human terms, which is what happens to the IFR in percentage points as you move from one age level to another. And here we're just showing above age 45, because you can see at the bottom of the age groups, they all get squeezed down here at very low IFRs. But as we go forward into the middle age groups and older adults, you can see that it's a very, very dangerous disease. Now, we do a lot of sensitivity analysis, terms that many of you will be familiar with because we're doing stability tests across age categories, and we document that this log linear relationship is remarkably stable across the whole spectrum of age groups. And other things that you might be less familiar with, like forest plots or funnel charts that are standard in meta-analysis, but not as standard in many economics and econometrics papers. So then the next step is to look at population IFR. And again, I wasn't sure what we'd find, but this graph seems pretty compelling, that once you've screened out some confusing seroprevalence studies or countries that didn't really succeed in doing comprehensive tracing, and you move those to the side, you start to see very clear patterns. What we're seeing in this picture is that the meta-regression explains roughly 90% of the variations across locations in the population IFR. I personally thought that was remarkable. I did not expect to find that strong of a relationship, but what it's telling you is that, for example, Salt Lake City and Iceland, New Zealand, and Geneva have very low population IFRs, 0.5 percentage point, lower than New York City that we saw before. Spain, Lithuania, and Italy is the highest here, almost 3% population IFR. So it's an enormous variation in population IFR across all these different locations. But the meta-regression tells us that 90% of that variation can be explained by differences in the composition of the age structure of the population, and most importantly, differences in the extent to which different age groups got infected. Whether most of the infections happen in young people who aren't very vulnerable versus older people, older adults and elderly people who are extremely vulnerable to COVID. And that's the message of this chart. Just to put it in context, we have in the paper a comparison with auto fatality risks, and in the paper we show you for Britain too, but here just look at the US. What you notice is that for people under 35, COVID's actually less dangerous than driving a car. And unfortunately, that partly reflects the extent to which some young people don't drive very carefully. But as you move into the middle age groups, you start to see that COVID becomes 10, 20, 50, 100 times, 1,000 times more dangerous than driving a car, extremely risky. And I think a key message there is that for a middle-aged person like me, I'm 58 years old, to go into a crowded restaurant where there's a substantial risk of my getting infected with COVID from someone sitting at a table next to me is a risk that I might not be willing to take. That would be like driving an extremely dangerous car, or even worse, doing something like free solo climbing, which I personally wouldn't do. I have a family and I just wouldn't take those kind of risks. And so for me, it would be irresponsible to put myself in a position where I could be infected with COVID because the risks are simply too high. The bottom line here is that COVID is not just dangerous for the elderly, COVID's dangerous for middle-aged adults. And I think that's important for us to understand as we think about public health measures and communications. Another key point here is that the population IFR of COVID should not be viewed as a fixed parameter. That has been done in some economic studies and some other kinds of studies, but really I think the message here is that protecting vulnerable age groups can reduce population IFR from 1 or 2% or more, all the way down to the success that Geneva had and that Salt Lake City had. They still had COVID infections, they still had fatalities, but they did a much, much better job in protecting older adults. And so there's a lot of open issues here. This is just one paper. More research needs to be done in the role of gender, race, and ethnicity and comorbidities and influencing IFRs across age groups and understanding more of the differences across locations. But we think this is an important start. So let me stop there